not in person of Dr. Asma Salahuddin Sharifat, the registrar of Lagos State University. Please, I would like to use this avenue to urge us all to be attentive as much as possible. And she's going to take us through the topic cancer, all what we need to know about cancer. Inshallah, I believe today's lecture as well is going to be informative and educative as well as entertaining. Assalamu alaikum wa rahmatullahi wa barakatuh. May I call on Imam Abdul Ghani Uraji for the opening prayer, please. Imam Abdul Ghani Uraji for the opening prayer. Okay. Then I call upon our Imam Misbah Salahuddin, sir. Can you please lead us on the opening prayer, sir? Opening prayer, sir.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إن الحمد لله نحمده ونشكره ونتوب إليه ونعوذ بالله من شرور أنفسنا ومن سيئات أعمالنا ما يهده الله فلا مضل له ومن يضلل فلن تجد له وليا مرشدا بسم الله الرحمن الرحيم. We thank Almighty Allah. We appreciate Him and we glorify Him for making it possible for us to meet today for our weekly webinar. As we are commencing today's program, we ask Almighty Allah to come along with us. We ask Him to give us success in the program, and we ask Almighty Allah for our lecturer, Dr. Asma Sharifa. We ask Almighty Allah to continue to strengthen her, continue to increase her in knowledge, and ask Almighty Allah to support her in delivering this presentation and to give us the understanding of what we will be learning from her today. اللهم يا معلم ابراهيم اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما ولا حول ولا قوة الا بالله العلي العظيم اللهم امين 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 يا الله.
We thank you very much, sir, for that short opening prayer. As well, sir, we are still going to call upon you for the opening remarks, sir. Brief opening remarks, sir. Thank you. Opening remarks. Imam Salahuddin is all over, sir.
Assalamu alaikum. Please permit me to invite Imam Abdul Latif Bello, the zonal missioner of Ogun Zone 1, to give the opening remark on behalf of his missioner. Imam Abdul Latif Bello.
You have the floor.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.
الحمد لله رب العالمين. We give thanks to Allah Ta'ala. Thank Allah who has given us the opportunity for having this webinar every week. This is one of what we have in NASFAD. This webinar is to give our members an opportunity to really know much about our day. It's being organized so that we'll be at our house at every week, and we be learning a lot. So I thank our chief missioners and all the members of the committee that are organizing this webinar every week. And I pray Allah subhanahu wa ta'ala shall continue to be with them and shall continue to be with NASFAD and make the NASFAD higher and stronger. Inshallah, I welcome all our members throughout the world who have joined us and those who are going to join us to please continue to join us every week. Allah will be with everyone of this. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. We thank Imam Bello Abdul Latif Adeleke for that short opening remark. We pray that may Allah subhanahu wa ta'ala in His infinite mercy continue to be with you, sir. I mean, without wasting much with the lecture, may I on this note call on our guest lecturer for today, who is a female from a well-known place, in person of Dr. Asma Salahuddin Sharifa, the Registrar Oncology Department of Lagos State University Teaching Hospital. Ma, you have the floor.
I stand on the existing protocol. I thank Almighty Allah for making it easy for me to be among my beloved sisters and brothers. So, inshallah, I'm going to start on cancer. Cancer. What are we supposed to know about it? All you need to know about it. But cancer is a broad topic. So I would say all you need to know about it. Just what are the basic things that if you see, you can talk to people about it and enlighten people about it. So
these are the introduction.
Assalamu alaikum. Doctor. Okay.
Assalamu alaikum. Can you hear me?
Yeah, we can hear you now. We can hear you now. We can hear you now, but
Okay.
there is a background noise from your hand.
Okay, the
there is a
background
background noise
noise.
from your hand. Yes, from your
Okay,
hand.
sir.
Thank you, ma'am.
Okay. Yes, sir. Sorry about that. Okay. So I'm going to talk about introduction. What we have is that cancer is a public health problem and it's a worldwide problem that's affecting all categories of people. And we know that the body is increasing in Africa, maybe because what we are exposed to now as compared to before, and the aging and the growth of the population is increasing. Transition, we're living better. So many things are changing now. So we call tumor cancers. We use interchangeably. We can use tumor, we can use cancer. So it's an abnormal mass of tissue that when they grow, normally in our body, as Allah has made it, we made sure that everything in our body changes. They renew themselves. There's something we call apoptosis. There's a time, after some time, the body will change. Another new cells will come up. Another new cells will come up. So when there's an abnormal mass of tissue, the growth of the cells, which has ceased, as in normally supposed to die and another one comes up, but it continues and it continues increasing in size, come uncoordinated to the extent that it's not doing the function of what it's supposed to do before. That's when we are thinking of that person having a tumor, a cancer around the body. So what are the risk factors? What are the causes? Most times we always say that causes are unknown, they are idiopathic. We don't know what is causing cancer. But there are some things that are there in our body, maybe from outside, that can lead to some people having it. Maybe they have this kind of thing, if it's excess, or if they notice a particular gene in the body, the person can end up having it. So we now describe the risk factors, modifiable ones. Modifiable ones are the non-modifiable ones. Non-modifiable ones are one, age. Some age, they have prevalence of particular cancer. While some other ages, they have prevalence of younger ages, some younger ages have prevalence of particular cancer. So it's not modifiable. It's not something that you can change that. Okay, I'm 50, I won't have this kind of thing. So it's not, it's part of non-modifiable risk factors. Then sex. We find some cancers in men, while we find some in females. An example, most breast cancers are found in men, about 99% are found in females, while about 1% them in men, because men still have breast. Like cervical cancer now, it's only women that has it. So the tendency of having cervical cancer, all the fallopian, uterus, you only find them in females. Then males, you see prostate in males. So those are the non-modifiable ones. Then genetics, some families, they have this gene that in their body, if they transfer to their family, to their generations, they have tendency of having it. So those ones are non-modifiable risk factors. Then the modifiable ones, maybe exposure to chemical agents, biological agents. So those agents, those are what we call carcinogens. Carcinogens are agents capable of increasing the incidence of neoplasms, capable of increasing the incidence of cancer. So are now divided into the biological agents, which could be virus. Some viruses, they found out that some viruses, when found in female cervix, an example is HPV. We call HPV human papilloma virus. Human papilloma virus can cause cervical. They found out that after checking people that have cervical cancer, they found out that they see more HPV in them. And now people that are sexually active, they have tendency of having, and they have this HPV, they have tendency of having cervical cancer. And some people that have HPV, they have anorectal, genital cancer. The HPV can also cause analogous cancer too. Then Epstein-Barr virus, that one can cause lymphoma. Those are all viruses. Then we have nasopharyngeal cancer, as a lot of viruses. We have osteolymphomas too. We have hepatitis B virus. Hepatitis B. We have hepatitis B virus, which later can lead to liver cancer. Why some they don't, doesn't lead to some people that have this hepatitis B virus end up having liver cancer. Then it could be bacteria. Some people they have H. pylori. After checking, we do some people that complain that they have ulcer and they've been treating for a long time, you know, and they now check the person has H. pylori. They find that some of them, it's not really ulcer that they're managing, it's more than ulcer. Maybe they have gastroscomas, they have carcinoma, so they end up having cancers, and they're thinking that it's ulcer that is there. So they find that H. pylori somehow related to people having these carcinomas and lymphomas. Then there's a association within bladder cancer and that's sometimes they call it patients having they call it children when we were young, then some of us go to water, we what they call using water, and some of them after some time they'll be passing bloody urine. So they need to monitor that kind of person. To occupation, some people they work in sawmills, so they're exposed to asbestos. While some people social customs, the people they are as a result of tobacco smoke. Maybe they are not even smokers, but they are passive smokers. Maybe they are around, they stay around people that are smoking, they might end up having all these lung cancer. Then environmental and food products, some food preservatives, when added to food, they are eating different kind of food now. What they use to preserve them, we don't know. So some of them, they end up having some food preservatives, especially to better or not, some not. After being infected with fungal infection, they could cause CA, cancers. Then arsenic, high fat foods, we need to be cautious about it. Alcohol intake, we need to be cautious about it. Iatrogenic, examples, cytotoxic drugs, some patients are exposed to some drugs are after taking them, they would have so they can be exposed to it. While some people estrogen intake after menopause, postmenopausal, they'll put them on some estrogen. They don't want to stop menopause. They want to continue doing their medicines. So long time exposure to estrogens also can cause it. Then radiation, ultraviolet. This one is majorly to those people that are maybe like albinos that, as Allah made it, Allah saw them very Benign, very important. It prevents us from being exposed to ultraviolet light. And so there's possibility of us having reduction in skin cancer as compared to albinos. So what are the cancer types? There are different types. Just know that any structure, any tissue in your body can end up become cancerous. It can be the eye, it can be the finger, it can be anything, any part of the body that can be cancerous. So don't let us think that maybe it's only cervix or breast, but for that there are some commoner ones that we see most often. Like in our clinic now, we felt that maybe because of what we hear, the genetic family histories could be the cause. Then cervical cancer. Cervical cancer, as a result of, we found that it's the second most common cancer around now. Then we have colorectal cancer. Colorectal cancers are cancers that we find around inside the colon. The colon, majorly the intestines, the colon, the rectum. So sometimes
Hello,
Ma'am.
continue.
Okay, where did I stop, ma'am? Where did I stop? I hope I'm not too fast.
Not at all.
I hope I'm not
Not at
I was a little in transit now. I want to be sure that I was able to deliver this before my journey back. So some people, so in men, most times the commonest one is prostate cancer and lung cancer, colorectal cancer. So the most common cancer in women is breast, followed by prostate, in generality, followed by prostate, then lung cancer. So I talked about small, bit by, but in our clinic now, we find out that we are seeing more breast cancer. And majorly, thing about breast cancer is that it's late presentation, which is what I mentioned about. Most people always say that somebody is doing them somewhere, that's why they are not coming to a city. Or maybe they have alternative things that they can use, but it would have boomerang, it would have extended to some other part that it cannot be cured again. It just be managed. So majorly, so I'm going to talk about breast. Most times, what they present is they present with a lump, painless lump, and that's always come with painless lump, like a small nodule in the breast, and sometimes under the armpit. And most common cause of cancer among women is the most common cause of cancer among women, and countries around, majorly in Nigeria, more than 1.1 million people now come with cases that are diagnosed, and more than 410,000 people now die of this worldwide each year. So the peak age now is around 35 to 45 years. So most of that we notice that maybe they have it in the family. We encourage them to go and do check. They do a breast check so that by 25 years old upwards, you start checking your breast. If you notice any lump, it's better to remove it and check what is inside than leaving it there that it's not paining you, it has been there, there's nothing wrong with it. So I said that before, and 1% in men. So even when if they find out that they have anything of such, they need to speak out. They should not keep it to themselves. And we talk about first degree relative. First degree relative is mother, father, sister, children, sister. So that is first degree relative. So 50% relative of 20 and 40. So that means people that have family tendency of having it, they need to be extra careful. They need to go for screening early enough as compared to normal population. So in the study, they found out that in this parity, I mean, when you give back more, and the pregnancy when you carry baby, and then breastfeeding those children too are protected. And most times when we have them breastfeed, we wanted to know how many years to breastfeed your baby. We wanted to know whether you have children. Because we find out people that are in parity, people that don't have children, that they are not married, not they don't have children, they are not pregnant. They have tendency of having for them. People that come to breast cancer, or maybe they come with breast cancer. We have invited them to screen. We screen for above 40 years of age. Anybody above 40 years of age, we do mammogram for them. Mammogram is a form of radiological testing. We help us to check the textures of the breast. We want to know whether there's anything going on in that breast. What's the above? At least once in okay. Mammogram, I think once in 3 years, there's nothing going on. So how do we treat? So we do surgery, radiotherapy, chemotherapy, hormonal therapy, and surgery therapy. Surgery in terms that, okay, because what we look at is that allow me to keep. And sometimes for some patients, we tell them they need to leave the two because there are some cancers that after affecting one, it goes to the second one immediately. So we don't want to take chances. We don't want the patient to get better and after some months now come back with another problem again. So we tell them. So the surgeons will tell us, okay, let's do it. But before we even tell them to go for surgery, that's what we are like. If you have any breast lump and they said it's cancer, come to us. Come to the oncologist. Let them start you on treatment. After starting on treatment, they will now advise you on the surgery. The essence of that is that if they start on treatment, we know the effectiveness of the drug on that patient. We know that, okay, this drug we are using, it has helped to clear the thing. But the essence of the surgery is that, okay, even perhaps there's still other things occurring around, we want to remove it so that it won't spread to other parts. Because in our management, work with two things. Either we cure or we do palliative. Cure for early stage, those people that come early. And for those people that come late, we do palliative. We don't want them to suffer. We don't want our patients to suffer. So we do palliative that, okay, if they come with a particular thing, we treat it. Okay, if they come with cough, we try to treat. If they come with, so it's like a prolonging the life. We don't want it to be like, okay, this cancer that has come will be the one that will kill me now. We want them to think away from that. We want them to a little better life compared to those. The painless lump will later become painful. Later become something that they don't feel before they start feeling. So once we try as much as possible to do that for them. Then the hormonal therapy depends. In breast cancer, there are some different types of breast cancer immunohistochemistry that we do, some tests that we do that want to know, okay, is it hormone dependent one? Is it the peculiar human? Is it the HER2 dependent one on some drugs to be sure about their management, how better off they're going to do on it. Then we do radiotherapy. Radiotherapy, sometimes some patients they would have done surgery, they would have something chemo. Because radiotherapy is okay, this is started my increase, started small. So we want to make it, we want to remove the minus ones everywhere, we want to make it better. And we want to try and remove those other parts so we use wages. So we send up for it, which is very costly. Right? Then we have cardiac therapy. Cardiac therapy now it's becoming better. That's less side effects as compared to the chemotherapy. That one treat go to the lung, to the breast, and target the particular breast lump or the type of breast cancer that we have, or any other part of the body. So that's about breast cancer. Then what are the preventions? Yeah. So we encourage self-examination. When we examine, we tell them they should use the flat of their palm, so that they will know if there's anything wobbly, any lump. And we encourage that they should do it at least 2 weeks before, 2 weeks after, and 2 weeks before their breast, before their menses. And for the postmenopausal women, they should be doing it at least once in a month to be sure that there's no breast examination. Sometimes the patient might examine and they might not be sure. So we see them, we help them to examine. Then we might even send them for investigation, we send them for mammography screening, mammogram. Sometimes we send them for ultrasound screening for those who are less than 40 years of age. So the genetic screening, for those ones that are family, maybe there's a family history of, okay, my parents, I had a patient that she had 5 of her siblings that had it, and the family members have had it. But the thing about it is that, if it's abroad now, maybe they would have done genetic tracing to be sure that there's something going on in the family. So for her, it was like when that patient, when her siblings they had it, so they presented to me. That's so it wasn't so in that kind of family, the tendency there's genetic transfer of cancer around them. So they need to do genetic screening for all the females, even for the men, to be sure there's nothing going on. So cervical cancer. Now, recently, I don't know whether they are still doing it on Lagos State. Lagos State. There was this one time that they were doing this cervical screening, they were checking the cervix, and if there's anything, they brought it down to the level of the health center to check if there's anything going on in the cervix, so that there could be prompt treatment, and which can be stopped if detected early. So we saw the second most common cancer in Nigeria. In Nigeria, cervical cancer is leading cancer mortality now, because it's inside. No woman wants to go outside and expose themselves and say that let's check me if there's anything. So now they encourage women that the centers now where those things are being treated, where those women are being checked. Most time now they put pillows. I know of Luke now. That in Luke, they will tell you that the people that are there, they are female, they are not generally. And so that you, like a sister now, can call another sister, come and see, to come and do it. And most times after, what we encourage are people that are childbearing or sexually active, they should have it done. So if there's anything, they could quickly, because it can be treated. If it can be cured, can be treated early if you present early. So about 8% of women present in advanced stage. That's the problem. Because it's an inner thing. Nobody knows there's something going on. So what are these factors? Most times, sexual factor, early exposure to sex, smoking, oral contraceptives. What do they present with majorly? They present with abnormal vaginal bleeding. They present with postcoital bleeding. Postcoital bleeding is after sex bleeding. They present offensive vaginal discharge. They present with vaginal mass. Some of them they'll complain that they're having something like drawing them down in their vagina. So for them, they present with weight loss. When you start seeing weight loss, maybe it has really inside the person, and the person is not knowing that it's coming from that side. So prostate cancer. A cancer on a man's prostate is what we call prostate cancer. So it's a small walnut-shaped gland that produces this semi-fluid. This produces the seminal fluid that nourishes and transports sperm. So most times you find it among men. So symptoms what they present most times.
Is there a kind of background noise, please, from your hands, from the
Yes, I'm trying to.
Thank you.
I'm sorry about
Thank
that.
you.
Yes, I'm so sorry about that. Okay. So where did I get it? Okay, what did they present with? Most times they present with abnormal vaginal bleeding, like the cervical cancer patients. Then after sex bleeding. Then offensive vaginal discharge. That means there will be like a watery discharge coming from the vagina. They might have lost weight. So prostate cancer, some of them they have majorly affect the men. And prostate cancer, the essence of why I put it there is that it produces seminal fluid that helps to nourish and transport the sperm that fertilize the woman. So most times, most men that complain about, they complain about the urination. And sometimes they might not even have any symptoms. So any detection thing around 40 to 25 years for average use. Hello? Hello?
Assalamu alaikum, we are with you. Wa alaikum assalam, we are with you.
Okay. So we encourage early screening for men around 40 to 75 years of age. So reason for high mortality in cancer. The reason why people present most times ones, they feel that some people will tell them, okay, if you take this drug, like that patient I told you that your family of them that she had the opportunity of saying, as Allah had this for her, she after she did surgery, but she didn't come back for 10. So she left. After 10 years, she presented back with metastasis. Metastasis means they have gone to other parts of the body. So I asked her that what happened? Why did you go? Why did you come and take drugs? She said because she lost her family. And I asked her, those people that you lost, did they present early the way you had it, the way you noticed early? She said, even that is telling me no, that it's because those drugs were very powerful somehow, and they died. And it depends on you. Allah gave you like 10 to come and be developing the symptoms. I think superstition and influence of spiritual belief. Sometimes some people will say it's attack. It's attack from somewhere. That's why somebody did this to me, and after that I started having pains in my breast. That's what I thought is an attack. So they don't come to hospital. They go to the alternative medicine, or they go to the other site. After it has boomerang, they come back to us for us to cure it, which is not possible at that time. Then self-denial actually is not easy. When we tell our patient that some of them had cancer, then they will tell you no, it's not possible. I know of a patient I had that was telling me that no, it's not possible. Me, I know God will not do that for me. I know God will not do that for me. So we have to counsel and talk to her that you need to take care of yourself, because it might not be easy for you to go back to if it's spread. But she was just Adam. So it's not easy. There's this self-denial that patients sometimes might not believe that it's true. There's fear of they will say, no, don't cut it, leave it go, and everything. Well, because of that, they might go, they might not come back. Or maybe when they come back, it would have been to a spread. Then lack of health insurance, like in Nigeria now, cancer treatment is very expensive. So they need support. It's not easy. Even the people that are rich doesn't pray for you, because it's not easy. The chemo, drugs, they're expensive. The they're expensive. So expensive. So you need for secrecy. Sometimes I had some patient that I was asking that, did you tell your, no, I didn't tell anybody. It's only me and my husband and my mom that knows about it. So thinking that maybe if I tell somebody else, they will think it's, so they are being secretive about it. So that's another problem. And after it has boomerang, that's why they will not tell me that I have this in my chest. It has been there for 3 years. So I don't know when it comes to secrecy. So the need for secrecy is a problem also for them. So how do you prevent it? Majorly when you look at prevention, you look at the primary prevention method, the secondary, the tertiary. The primary prevention is what we are doing now, that's education. We want people to know that cancer can be cured and can be management, and there's a palliative part. Palliative part is when you come early, it can be treated. And you need to follow. That's another problem. After being cured, after telling the person that you are cured, they won't come back again. They will not go. Because it's a challenge of recurrence. So they will not go and maybe come back like 5 years, 6 years with another problem. Which they could after follow up. Because when we do follow up, what we do is that we give them like 2 weeks, then we increase it to like a month, and we increase it to like 3 months, and we see like 3 months like a 3 to 4 visits, and we increase it to like 6 months, 2 to 3 visits, and we increase it like a year, or to 6. Then maybe like after 3 years, maybe after 5 years, we tell them. Then to maybe for a longer time, maybe like 6. So we have some patients that are 15 years above. Nobody ever coming back today. The essence of the primary education is to reduce and eliminate the exposure. So, for example, use of vaccination for people that are cancer now, adolescents can be vaccinated around that 9 to 13 years for male and female. And for the tobacco, for people that are smoking, to tell them to control it, to stop smoking as much as possible, so that they can have a good health and they might not have tendency of having lung cancer. Then secondly, prevention. That's when we do training, we do early detection. We tell you to go and do mammogram, do pap smear, cervical pap smear for cervical cancer. We do cord blood test for people that have colon cancer. So then for the tertiary treatment, that's at the tertiary center, the teaching of people. After detecting, immediately we prompt diagnosis. Okay, what are the tests that we do? Prompt diagnosis and treatment. So what is the investigation? So what is the take home from part of the investigation I want to know about is that any tissue that is taken out of one body should be taken for histology. Most of our patients, some of them, they've had a long being removed from them. And this is not people that are not elites or people that are not knowledgeable, educated. They come back to tell us they remove the stuff, but we didn't collect it from the doctor. Or they remove the stuff, they treat it away. So we encourage that they should do histology on it, to do tests on it. So we do tissue cytology, we do biopsy for histology too. We take samples from that lump and do tests on it. Before we now tell anybody above 40, when you see a lump in the breast, we are very suspicious about it. You don't want any other person to just go and do surgery on it, so that it's not spread. Just by touching it, it can spread. So one has to go to the people that knows about it before sampling is very important. Then, histochemistry, we want to know the kind of cancer it is. So we do tumor markers. We take tumor markers. Tumor markers will tell us if there's anything going on. So treatment is multidisciplinary approach. It's not only doctors, it's not only the oncologists that treat. We invite the surgeons, we invite the radiotherapy, we invite the nurses, we invite the psychologists too, because it's not easy. And sometimes some patients here they get depressed, everybody in the family, they won't even talk to the family again, they don't want to see anybody again. So we invite the psychologist. So it's a multidisciplinary approach when we are treating them. Very important. So in conclusion, from what I just said, I will say that cancer is one of the public issues around that is affecting all ages. So we don't look worldwide. We don't look at it as if, okay, it's a particular age that is only affecting, and it could affect any part of the body. Presentation screening is a key solution to it. So there are so many practices on it now compared to before, which is helping us to develop more treatments, getting patients to get better as compared to before. So my major take home is that any patient that will take sample from, they should take it to hospital. Very important. It is very, very important. So we need to do histology on it. That will confirm the kind of lump it is in the body. So from this, I will say, I will stop on this note.
Wa alaikum assalam wa rahmatullahi ta'ala wa barakatuh. At-takbir, Allahu Akbar. At-takbir, Allahu Akbar. At-takbir, Allahu Akbar. We thank our doctor, Dr. Asma Salahuddin Sharifat, Registrar Oncology Department, Lagos State University Teaching Hospital, for being justice to the topic cancer. We pray that may Allah subhanahu wa ta'ala in his infinite mercy continue to be with you May Allah subhanahu wa ta'ala in His infinite mercy continue to guide you and protect you. May He continue to give you abundant wisdom, knowledge, and understanding. At this junction, without missing word, seriously, at this juncture, I have to personally pray for NASFAT. NASFAT has really done well for organizing this kind of a program, which is informative, educative, as well as enlightening. Wallahi, I think today's topic as well is continue to nourish the knowledge, continue to give understanding from above in the name of Almighty Allah subhanahu wa ta'ala. Ameen. So at this juncture, dear listeners and participants, we move to the next segment. This is the question and answer segment. So dear listener and participant, please, you can use the question and answer box to send your question. You have a question and answer box on the screen. You can type and send your question in that question. May I first ask our guest lecturer, Dr. Ma, my question is the causes of prostate cancer in men and how to avoid it. Causes of prostate cancer and how to avoid it. Thank you, ma. That's my own personal question.
Assalamu alaikum warahmatullahi wabarakatuh. Okay, we found that majorly prostate cancers are found in men. Like what I said before, in in cancer, because we don't know. So what we just encourage people is to do screen, just like breast cancer too, because we don't know. But we encourage that you should screen yourself. Then what we mean by screen is that we do like PSA, we call it prostate specific antigen. When you are 35 and 40 above, you check so that you know your normal prostate specific antigen. When you notice that doesn't mean one will develop cancer. That doesn't mean one will develop if there's anything going on, then maybe now you can invite you can go to the doctor to tell them that I noticed this thing has increased compared to when I was at a particular age, and is stable, just going higher. So if there's nothing going on, because in prostate there are two things. There could be benign. Benign is just a place, just swell up. Doesn't mean there's a cancer. So it's when they check that they find that there's nothing, and you'll be able to say, okay, there's no cancer here. With the function, we studied. The reason why it's becoming cancerous later is unknown yet, like every other cancer. What is possible? So we just say that we tell people you should avoid, you should encourage them not to take alcohol, not to smoke, and to eat well balanced diet as much as possible. I think I answered that question, Abi. So
you have another question in your question and answer, which is you mentioned that from you mentioned that pain is not associated with cancerous masses. What then is the cause of pain in breast of non-breastfeeding women? Noticeable pain in intermittently. Assalamu alaikum.
I did.
Assalamu alaikum. Okay.
If a person complains about the pain, sometimes it might be the weak side. Sometimes it might be why it's menstruating in their breast. So if you are finding out, you are noticing that there's something going on, you complain to the doctor, let them examine you and be on watch for you. That doesn't mean, when they say something in medicine, they'll say 99% are like this, but 1% might be the other way around. So for most times, the what they call it, the marks that they see, most times they are always not painful. But some might be painful, but not most times. That's why patients present late. Because when they see the lump, they will say it's not painful. They are not worried as compared to seeing the pain and trying to take care of it immediately.
But this one more question. Question, please. Question? More questions for our doctor. In the absence of no question, again, I believe the topic of discourse for today is well treated, and it is lucid enough for us to be with Dr. Asma'u Salahuddin Sharifat. We pray that Allah continue to guide and protect you. And we believe that when next we call on you, we are going to honor our invitation. Inshallah. So at this point, may we now move to the next item on the program, which is the closing remarks. May I, on this note, call upon Imam Salahuddin Misbah Olagunju on behalf of the CM, the Chief Missioner of NAFA, to give us the closing remarks. Imam Sam.
We have the Andrew here. Please permit me to invite him. To give the closing remark.
All right, sir. Okay. Imam Abdul Rodi, please, sir, you have the floor for the opening remarks, sir. Imam Abdul Rodi.
Warahmatullahi wabarakatuh. Hello, can you hear me?
Wa alaikum salam wa rahmatullahi wa barakatuh. Yes, loud and clear. Wa alaikum salam, loud and clear.
I apologize, I'm on the road.
Wa alaikum salam.
I keenly followed the lecture delivered by Ajia Dr. Sharifa. It was indeed informative and educative. I pray to Allah subhanahu wa ta'ala to reward her abundantly for creating time to share our beneficial knowledge with us this evening. Honestly, we benefited immensely from our wealth of knowledge and experience. May Allah subhanahu wa ta'ala continue to strengthen her. May Allah subhanahu wa ta'ala bless the knowledge that she has shared with us this evening. And on behalf of the Chief Missioner of our society, and also all members of the NEC and all members of Nasrullah Party, we truly appreciate the effort you made this evening, and we pray Allah subhanahu wa ta'ala to continue to use you for greater services to humanity, and particularly to Islam. We appreciate you, and then we also appreciate members of the planning committee for planning such a wonderful webinar that we just had this evening. You've been doing a wonderful job. My prayer is that Allah subhanahu wa ta'ala will continue to and the effort that you are making, pray that Allah will reward them in your books of good deed, and He will reward you generously and handsomely for those of judgment, of the chairman of the President of Mercy say thank you to everyone for creating this webinar, and that's the knowledge that we have received from Doctor this evening. Your lab blessings. May Allah also make it to other people who need it. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين. صلوا على النبي الكريم.
On this note, we come to an end of today's prayer. اللهم ربنا وتب علينا يا مولانا انك انت التواب الرحيم. اللهم ربنا ظلمنا انفسنا وان لم تغفر لنا وترحمنا لنكونن من الخاسرين. ربنا آتنا من لدنك رحمة وهب لنا من امرنا رشدا. ربنا هب لنا من ازواجنا وذرياتنا قرة اعين واجعل اللهم اغفر لنا وميتنا وصغيرنا وكبيرنا وذكرنا وانثانا وارنا وابنا وادرنا وغائبنا وطعنا وآتنا برحمتك يا أرحم الراحمين. اللهم ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. سبحان ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين. السلام عليكم ورحمة الله. May we meet inshallah in good health next week. سبحان ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين. الحمد لله.
Ṣé yá ń bá máa lè fẹ́ jẹ́ jàmálà? Èèyàn ìlú
ṣé ìgbé abẹ́ tí wọ́n ń pàṣẹ? Ẹ lè wọ́n pàṣẹ.
Adé ń lọ ni.
Ẹ má bínú mà.
A máa jẹ́ inú mọ́tò.
A máa jẹ́ inú mọ́tò.
Ó jẹ́ ní kékeré àyàbò jẹ́ kọ́dà tí mo ṣe.
Wọ́n ti lọ sàlẹ̀, wọ́n fẹ́ bẹ̀rẹ̀ sí lọ sàlẹ̀. Ẹ ṣe má bínú. They know 2 minutes. They have difference there. Like, so many things about the same device. What is this thing that they did there?
Okay. So everybody. Oh yeah, Mate. Mélòó ló ti tẹ̀? Oh yeah, tẹ̀ méjì sí. Say now.
Kò dúró síbẹ̀. Báwo ni wọ́n á fi resume school? Bẹ́ẹ̀ ni